Okay, well, everyone, welcome to the teaching. Dr. Whitman's going to do a presentation first. I'm just checking if it's working.
Well, she's just checking her tech. So yeah, welcome to the first primary Zoom teaching. This is very much in its infancy. So any feedback or any ideas would be great. Standard Zoom etiquette applies. So if you're not talking, could you put your microphone on mute? So there's not too much noise or any feedback going on. Also, there is there's a chat associated with this Zoom. So if you have any questions, you can put them in there and we'll either answer them at the end or as we're going along. And this is being recorded, so don't say anything you don't want to appear on your GMC record. There are obviously going to be technical issues as we go along, as we've probably all had Zoom chats with our family and know that it all goes wrong at one point. And we'll also get thrown out at 3 o'clock, well, 3:15. So at 3:30, we'll have a little break and then restart the meeting so we don't get chucked out when the thing runs out. So Zoe, do you want to start off? Is your time limited? Is your work?
Yeah, if that's all right. Are you on your laptop?
Yes.
Or on your iPad?
I'm on.
Can you share
your presentation?
Yeah, because I haven't got any. It won't do the whizzy things that I wanted. So, if that's okay. So I apologise if I get interrupted. As you can tell, I'm at work. They have promised not to interrupt me and phone me. Dr. Flint may stick his head in just to take the piss because apparently that's fun. But hopefully it should be able to do it without getting interrupted. Let's see if this works. Thank you.
Everyone see that?
You've made them turn all their microphones off. I can see it.
Yeah.
So obviously I can't tell who's there, but my name's Zoe. I'm one of the intensive care consultants at the Royal. I do anaesthetics as well, but haven't done it easier since February because of pandemic. This is what we've been doing for the last couple of months. I think Shiv sent a thing around to see what you wanted, and quite a few of you asked about ventilating COVID patients. So I've tried to put something together for you, which might make a little bit of sense. And then if you have questions, I'm willing to try and answer them for you. Click on, Dave. Basically, this is, if you've been struggling with it over the past couple of months, don't worry about it. It's really difficult. We're struggling too. Glenfield, who are the tertiary referral centre, the consultants there are finding it difficult. So don't feel bad about it because these are not easy patients. Right. So from kind of a practical point of view and an exam point of view, I've tried to come up with some stuff that might be interesting to you. So we're going to talk a little bit about ERDS. I'm going to explain to you what P-SILI is and how to decide when to intubate somebody. A bit about conscious proning and ventilator proning, and then a bit about the different subtypes of COVID and why we ventilate, do, and what the reasons for it all beforehand are, hopefully. So, from a definition point of view, I'm afraid this is going to be because I can't really ask you questions. This is the definition of ARDS, according to the Berlin definition, which was published in about 2010. It's very wordy, not very easy to learn, but you vaguely know what it is for your exams. The easier bit to learn is the next bit, which is the diagnostic criteria, basically. So that is, click on, that is acute, which is obviously the first word, so fairly rapid. You need bilateral opacities. So basically, most of the lungs will be, you'll see some infiltrates on either whatever imaging you've got, whether that's a chest X-ray or a CT. And then a PF ratio of less than 300, or which is less than 40 kilopascals if you work it out. And PF ratio is arterial oxygen versus your FiO2, so how much oxygen you're putting in versus how much is getting into the body, on a minimum of 5 of PEEP. And then the final bit is that it's not cardiac failure that's causing it. That must be a respiratory pathology, not wholly a cardiac pathology. It's classified into mild, moderate and severe, obviously associated with increasing severity. All of the papers are published in millimeters of mercury, which gives you much nicer numbers than the kilopascals. But kilopascals are what we practically use in this country, so that's kind of what you need to work out if you're going to actually do it. The moderate and severe are the ones that definitely need intubation. When you get into severe, you get to at least about 45 to 50% mortality, and the ones that we think about referring to ECMO. So that's ARDS. Flick on. Is he still there or is he gone? Oh, there we go. So PCILI stands for patient self-inflicted lung injury. And it's how you get lung injury before the patients are intubated, and it can contribute quite significantly to their pathology needing them to be intubated, and then also make life much more difficult once they're ventilated. And it's caused by very strong respiratory effort. So if the patient, look at a patient and they're working really hard, taking really deep breaths, using all their accessory muscles, getting really large negative intrathoracic pressures, you can see that it's causing stress on their tissues, and that increases the amount of inflammation within their alveoli. You get fluid leakage, you get changes in the vasculature, and increase the inflammation that's going on. The aim of all the different types of respiratory support we can do before intubation is to try and reduce the work of breathing, and so reduce those high negative pressures. We do that with high flow, which just gets more oxygen into them at higher flow rates, so they don't have to work as hard to get it in. And we can do that with pressure, whether that's CPAP or BiPAP, non-invasively. This is a kind of a general point, but particularly we're finding with COVID, I don't know if you guys have seen it as well, but hypoxic patients are often pretty comfortable. What you need to go on, if they're comfortable, they don't necessarily need intubating, you just need to give them oxygenation support, so often high flow or CPAP. But you need to have a look at what their respiratory distress is to decide whether to and when to intubate. So if they're tachypneic, if their volume is rubbish and they're just in their because they're taking that really shallow breaths, or if they're taking really big deep breaths and working really hard using all their accessory muscles, then you need to think about intubating them earlier, and so reducing PCILI, because it causes quite significant problems later on. PCILI is quite a new term. It's only kind of appeared in the last 2 or 3 years, but there's quite a lot of research going into it at the minute to try and help decide what to do about it. So that's that. You may have seen in the news, or you may have seen people doing it in hospital, doing conscious ventilation. So I thought I'd just talk about that very briefly. You can move on, Dave. They are There's not very much evidence for it. It's still quite a lot at the moment. But there's been a few case series based on conscious proning, both before this pandemic happened, and there's been just this one at the bottom since the pandemic. So the idea of proning is that it improves your ventilation perfusing matching and reduces shunts, because you get more, the lung aeration is more consistent through the lung. So if somebody's needing oxygen and able to communicate and able to move themselves around the bed, you can get them to lie flat on their front. And ideally they stay there for a couple of hours at least. Some people are a bit uncomfortable, and obviously if they're really hypoxic or really struggling with their breathing or unstable, then you won't get them to do it, but they're doing it quite a lot on the medical wards. Or they were doing when we had lots of COVID patients, to try and avoid respiratory deterioration, particularly in the ones that we've said no to and aren't going to come to ITU. The only study so far is this one in New York, which found that it didn't look at outcomes at all, and it didn't have any controls. It just found that the patients improved their SATs from an average of 84% to 94% when they got them when they self-proned in ED. Difficult to know how much that means, but they're doing more studies on it. So it's an option if you're struggling. And we've certainly got some of our patients to do that when they've been spontaneously ventilating, to try and avoid the need to intubate them. So if we move on to ventilation, when it catches up. Like I said at the beginning, it's tricky. It's not an easy thing to do at all. So don't feel bad about it. Come on, thing. There we go. So I'm going to talk, hopefully you've heard of lung protective ventilation. It came as part of the ARDSNet trials in the 90s, I think. If you want a bit more information, if you go to the ARDSNet website, just Google ARDSNet, comes up, and it goes into a bit more of the evidence behind all of the different parts. So I'll go, these are the main points, and I'll go through a bit about all of them just to try and get the, explain them to you. And then we can have some questions at the end if necessary. So firstly, we aim to limit tidal volumes to 6 to 7 mils per kilo. Now that's based on ideal body weight, which is based on height. So you need to measure the height of the patient if you can, or estimate. Because obviously if somebody weighs 200 kilos, you're not going to do 7 times 200, 1400 mil breaths. That's way too much. So you need to base it on the height. And that's all aimed to reduce pressure and volume damage to the lungs, and to reduce ventilator associated lung injury, basically. Dave, if you click on, there's a little bit extra for each bullet point. I don't think there was anything else on that one. So yeah, limit the tidal volumes just to prevent over distension. PEEP. So ARDSNet suggests very high levels of PEEP. I think their maximum PEEP level that they suggest is up to about 24. And we don't generally go that high. And actually we're finding that the COVID patients don't need that much PEEP. We initially thought they were going to need lots of PEEP, but we're tending to find that 10 or 12 of PEEP is plenty. You want to make sure you get the right amount. If you have PEEP that's too high, their pressures are high and you can't ventilate them over the top of that without overly distending their lungs or causing gas trapping. If you have not enough PEEP, then you get atelectasis and basal collapse and worsening oxygenation. Generally, as a rule of thumb, if they're needing increasing oxygen levels, definitely if their FiO2 is over, if they're needing greater than 50% oxygen, then they should be on more PEEP, so up 8-ish. Sorry, if they're needing up to about 80% oxygen, they should be on at least 10 of PEEP, possibly 12 as a general rule. If you look at the graphs at the bottom, you can bring these up on the ventilators. Most of the units around the area use Drager ventilators. If you click onto the pressure volume loops and change the view, you can bring this up if you want. So if you look at the one on the left, that's somebody who's not got enough PEEP. So as you increase the volume changing, it's going flat along the bottom until you get to a sudden point where there's enough pressure to suddenly open some alveoli, and then you get an increase. If you look at the one on the right, as the pressure increases, the volume also increases straight away, so they've probably got a reasonable amount of PEEP and you might be able to reduce it. So if you're not sure if somebody's got enough PEEP and you're struggling with oxygenation, then open up the pressure volume loops and see if you can use them to help you. If you've got a lot of water in the tubing, then you can end up with a very squiggly graph that's not very helpful. But if it's all right, then you can use these to help you out. So that's PEEP. I've forgotten what the next one is and I can't read it. Sorry. Oh yeah, plateau pressures. So you have high going to cause trauma, you're going to cause pneumothoraces, pneumomedial. And we've definitely seen quite a few of these with COVID patients that are very difficult to ventilate and needing higher pressures. Ideally, you'll keep your top pressure less than 30 centimetres of water. That might limit your tidal volumes. If you've got very uncompliant lungs, you won't be able to ventilate to get good tidal volumes with that. So you might need to tolerate arterial carbon dioxide, so what's called permissive hypercapnia. And as long as their pH is greater than about 7.2, it doesn't cause any significant cardiovascular instability. So we tend to tolerate it. What you can do is do what we call inverse ratio ventilation. So you have a prolonged inspiratory time and a shorter expiratory time. And that increases your time at a higher pressure. So it increases your plateau pressure on average to try and improve things. And the extreme version of that is APRV, which I haven't really talked about, but if you want me to do at the end, I can. I'm not going to do it right now, but that's the idea of inverse ratio ventilation. So if you're struggling with needing high pressures and struggling with oxygenation, you can do inverse ratio. The problem with it is if you have somebody who's got significant asthma or COPD, and then if you don't give them long enough to breathe out, they can get gas trapping and lead to instability from that side of things. So you just need to be careful that they are. If you look at the flow loop, the flow graph on the ventilator, that when they breathe out, their flow is getting back to 0 before they breathe in. I haven't got a picture of that, sorry. So if you have a look, if you get somebody at work to show you on it what to look for next time you're in, that will probably help. The next one is avoid hyperoxia. So if you only need SATs, you don't need SATs of 100%. We've actually been aiming for about 90%. Having too much oxygen around causes atelectasis and it causes inflammation and can worsen lung injury. So if you aim for a lower SATs and PaO2, then it will reduce the risk of that being a problem. And don't wait for a gas to come along. As long as you've got a reasonable SATs trace that you can believe, and they've got sats of 100, just turn their oxygen down, and just keep turning it down until their sats drop to about 90%, and then leave it there. If they've got sats of 98, turn it down. If they've got sats of 85, turn it up. Don't worry about the gas. We're finding, at least initially, they're going to need deep sedation and muscle relaxation to get them stable. Now, obviously, they will get that when the tube goes in anyway. So most patients on ITU, as you tube them, you can sort of get under control before the rock uranium or whatever you've given them wears off. But a lot of these COVID patients are quite difficult to ventilate, and particularly oxygenation in the first 24 hours can be quite tricky, and they need to re-recruit quite a lot. So you can do muscle relaxation to try and improve things, and it also reduces their oxygen demand by reducing the muscle activity. So if they're not syncing with the ventilator and you can't get their sedation under control, or if you simply can't oxygenate them, then you can do a trial of giving them a bolus of muscle relaxant, see if that improves things. If it does, then put them on an infusion for 24 hours and then review it again the next day. It can reduce the patient interfering in the ventilation, just let you take over and do everything for them, and that can help quite a lot. Some patients it makes it worse, so it's worth giving a small bolus first and seeing if it improves things. If it does, then carry on. If it doesn't, just leave. Obviously, don't repeat it. The problem with doing muscle relaxants as an infusion long term or longer term for several days is that they significantly increase the muscle weakness and ICU acquired weakness that they get, and rehabbing becomes a lot more problematic. So only do it if you need to, but it can be very helpful to do, and it's worth a try if you're struggling. Conservative fluid management, now that is all about reducing extravascular lung water, which will increase the amount of distance that oxygen has to travel from the aerated alveoli to get to blood, to get to the capillaries. So it reduces gas exchange. When you guys go and do some work at Glenfield as their tertiary referral centre for severe acute respiratory failure patients, they spend all of their time drying patients out by giving them furosemide, which means they end up having to filter patients quite a lot and put them on NORAD because they're all hypovolemic, just to improve their lung function. And we assumed that it would be the same with the COVID patients. What we're actually finding is that most of the patients have been feverish and hyperventilating for days and are actually very, very hypovolemic when they come in. So we're actually needing to give them fluid, but just be sensible about it and don't give them buckets of fluid. We're doing some lung ultrasound, which I've got some pictures of in a bit, which can help you to see if extravascular lung water there is, and help you decide whether you want to give more or whether you want to try and dry the patient out a little bit. So conservative fluid management is not don't give them fluid, it's be sensible about it. Don't make them 6-10 litres positive, yeah, just make sure, just give them fluid if they need it, but don't give them too much, basically. Recruitment manoeuvres. So the idea of those is normally when you're breathing, you take nice regular breaths, and then every now and again, without realising it, you'll do a big sigh and open up the bases of your lungs. Obviously, when you're on a ventilator, the ventilator doesn't do that. And it can be very useful if you've got somebody who's hypoxic to try and see whether they are recruitable and they've got bits of lung that are able to be opened up by increasing the pressure. There are different ways of doing it. The best way to do it depends on the patient, usually, and what ventilator you've got. Some of them are easier to use than others. What I would say is don't disconnect the ventilator and put them on a bagging circuit, or because as soon as you do that, if you disconnect them from the ventilator, they de-recruit automatically. And then you start bagging them, you have no idea what pressure you're delivering. And then once you bag them and got their sats up, you then disconnect them again, so they de-recruit again and go back on the vent. So you may damage them by giving them very high pressures, and then you've undone all the good you've done as soon as you've disconnected them. So it's actually not helpful to just disconnect them and bag them generally. You can do it on the ventilator, and you can do this in theatre or on ITU. There's different ways of doing it. The way I usually do it, which is the simplest way, is to do an inspiratory hold. And I tend to turn the inspiratory pressure up from whatever it's normally on. So initially put it to an inspiratory pressure of about 30, and hold my finger on the inspiratory hold for 30 seconds, and see what happens. I may then do it a bit higher, depending on what the patient's response is. While you're doing it, you need to watch the monitor, because having a consistent high intrathoracic pressure, you are reducing their preloads, you're reducing their venous return to their heart, and they can get cardiovascular collapse if they're dry. So obviously if that happens, stop doing it and let their heart refill, and it should improve. And generally warn the ITU nurse that you're doing it, because they get a little bit upset if suddenly the monitor starts bleeping, and they don't know why. So that's the way I usually do it. Another way to do it is to put them onto APRV, which is a similar way of doing it, because it's prolonged high pressure. So it does basically the same thing. The other way, the way that's described on ARDSnet, is to do stepwise PEEP increase. So increase their PEEP and their inspiratory pressure by 2 and keep going until you don't get an improvement in their tidal volumes. That takes quite a while, and they do it a lot in research. It's actually not very practically useful, so I find that the inspiratory hold is more useful. And once you've done the recruitment manoeuvre, you usually need to increase the PEEP to try and keep it open. So that's what I do. And then finally, prone ventilation. So if somebody's persistently hypoxic, so if you're needing over 60% oxygen and a PEEP of 10 or more, then consider proning. And you can use lung ultrasound to try and help identify which ones are likely to respond to it and which ones aren't. So if you click on Dave, I've got a slide on prone ventilation a bit more. I would guess quite a few of you have been involved in proning in the last couple of months. If you go and work at Glenfield, they do it all the time. We've not really done it very much at the Royal before, but we've done it a lot now, so we're actually fairly practiced at it. The whole point of it is that it improves your ventilation perfusion matching. So normally when you've got a ventilated patient lying on the back, just due to gravity, your posterior lung area gets consolidated, collapsed. Obviously becomes the back, and the back becomes the front, and it's much easier for those areas to ventilate. If you go back to your West physiology, West zones, just because of gravity, the upper ones ventilate more, and the lower ones ventilate less. So if you flip them over, you flip that round, and it also alters the blood flow. You get better secretion drainage, or you can do, so it gets the secretions out that way. And if you've got them positioned properly, so you normally have pillows under their chest and shoulders and pillows on their groin, and the idea of that is to get their abdomen off the bed, or mostly off the bed, so that it's free, so that their chest isn't expanding but their diaphragm is, and that increases your basal lung recruitment. If their abdomen, if they're quite large, then you might need multiple pillows to get their abdomen off the bed. But that's if their abdomen's on the bed and you can't really get your hand underneath it without really shoving, then they're not, there's not much point in doing it because you're not getting them off, you're not improving the recruitment enough. And you're likely to have seen people doing lung ultrasound over the last few months as well. And that can help work out whether somebody's likely to respond to proning. So the top one is a normal lung, and you get A lines, which are a reverberation artifact. So you get your bright white pleural line, and that you get that repeated over the repeated down the image, and that's normal aerated lung. You can't see ultrasound waves don't pass through air, so you just get a repeated pattern at the top, the first couple of centimeters of image. B lines are what you see when you've got a lot of lung water. So it's those, they're called comet tails, so you get those white lines that go all the way from the pleural line, haziness that goes all the way to the bottom of the image. That's a pretty solid, very wet lung, that one. It's common to get 1 or 2 in the lung bases of normal patients. But what we're seeing with the COVID patients is that their anterior chest looks completely like this all over. And you can often see it at the bases as well. If they've got a B-line profile throughout, then they probably won't respond to proning that much. From an aeration point of view, it might alter the regional blood flow enough to make some improvement, but they're less likely to be a responder. If you've got basal consolidation, like the bottom picture, so that's looking at a lung base with the curved white line on the right being the diaphragm, and a little bit of a pleural effusion, which is the black between the lung and the diaphragm, and you get a kind of speckled pattern of looking like dense solid tissue. If you've got basal consolidation or posterior consolidation that you can see when you look all over their chest with the ultrasound probe, then you can they're more likely to respond for the reasons that I mentioned initially to proning. So if I do a lung ultrasound, I'll look anteriorly on both sides of their chests. If they've got COVID, I'll expect to see B lines everywhere. I also look for lung sliding, but that's a separate talk, to see if they've got a pneumothorax or not. And then I'll have a look at the bases of their lungs, so kind of in their armpits down to find the diaphragm, and have my hand right against the bed so you can see the back, and see if they've got consolidation. If they have, then proning is more likely to be helpful. If you're going to do it, you need to do it for 16 to 20 hours, and probably for several days in a row, to see whether you're to kind of get a sustained effect. And what you normally see is they're a bit unstable when you turn them, and that might be cardiovascular or respiratory or both. And once you've turned them, then you'll see the FiO2 come down quite significantly if they're going to prone, if they're going to respond. Prone somebody on Saturday who was on 100% oxygen, and 2 hours later he was on 40%. So it can make quite a significant difference. You need somebody experienced on the airway to do the turning, as I'm sure if you've done any prone in theatre cases, then you're turning them over and keeping them safe is quite tricky. And you need some sort of checklist to make sure that you do it right and don't miss anything. And the nurses will do pressure care for all of the face and their limbs, and then turn their head from one side to the other every 4 to 8 hours. We've been doing it 8 hourly, which is what Canfield do. So if they do it, we can do it. So hopefully that makes a little bit of sense about proning. And a little bit about ultrasound. Next one, I can't remember what I said next. Oh yeah, so subtypes of COVID-19 lung pathology. They seem to have different stages of disease. There's a guy called Gattinoni, who's an Italian, who's very enthusiastic about lung physiology and lung pathology. He's the one that initially came up with alternate ventilation, the concept of the baby lung, which you can go and look up if you want to. But it leads to all of the lung protective ventilation that I've already talked about. So he's written a paper in April, which suggested these two different subtypes of COVID-19 disease, which I will talk you through. Type 1 is what he's calling type L, or non-ARDS, so low, it's low elastance disease, which means they're very hypoxic, but they have very compliant lungs, so you don't need very much pressure to ventilate them. When they're awake, they often have a high minute ventilation, but they don't look particularly out of breath. They can take good big breaths without too much of a problem. And then when if you do a CT scan, they have a very low lung weight, so there's not huge amounts of consolidation. You click, Dave. So you have a CT scan, and they've got a lot of aerated tissue there. There's not too much going on, and actually they need very little PEEP. So a PEEP of 8 to 10 is usually enough. And if you go up, it doesn't actually change how much oxygen they're on. You click again. It doesn't really change what they do, and you might, because they're not recruitable, they haven't got that much. It's fairly homogeneous disease. Whereas the type 2 subtype is patients who've got a high elastance, so a low compliance. They're still very hypoxic, but they need much higher pressures to get the same amount of lung distension. And if you CT them, they tend to have much more extensive consolidation. So it's called, if you were to weigh their lungs, they'd have a high lung weight because there's a lot of water there. So there's a picture of that, which may be coming. There we go. So as you can see, normally they've been ventilated for a little while, so they get very dense posterior consolidation. You can see air bronchograms. And if you were to prone that person, they probably have a reasonable response, and they're more likely to have a good response if you increase their PEEP, because there's lots of recruitable lung tissue there. So there's these two different types of COVID-19 theoretically, and what we're seeing is that when patients are initially admitted, they're usually the type 1, so they're relatively compliant, putting more PEEP on. They need a lot of oxygen, but putting more PEEP on doesn't make a huge amount of difference. They might have a proning response for a day or two, but actually not much changes. And then they get stuck for a while, and then they end up they either get better, or about day 10, they end up in a type 2 phase, where they get more hypoxic again, they've got posterior consolidation, and very, very high lung weights. And they need proning a lot, and either you continue like that for a while, or they die. On the next slide, I've got a table which is his suggestion of how to treat all of these patients through. There's quite a lot of information on there, so if you're interested, the best thing to do is to probably look at the reference, which is at the bottom, and look at and try and work your way through it. But basically, it's what you're aiming to do and what your options are for each bit. So before intubation, you're trying to support them as you can and avoid going peacefully. When you're ventilating them, you do the normal stuff, lung protective ventilation that you can, and try and reduce oxygen demands and kind of conservative fluid management. And then depending on whether they're type L or type H, or type 1 or type 2, use lower or higher peaks, and prone them or not. Weaning, there's a section on weaning in his thing. Nobody really knows. I mean, nobody knows how to wean patients reliably in ITU at all. So I don't know why we would be expected to be able to do it in COVID. What I'm finding is that in COVID it's slow, and it takes a really long time, and you have to take even longer than you think you would. So what we've been doing is, if you think they can go on, you can change from BiPAP to CPAP, and we wait another 24 hours before we do it. If you think they can be extubated, wait another 24 hours and then do it, because otherwise they fail. They still might fail, but it takes longer than what we're used to doing. So yeah, it's just trying to keep them strong, and take time. And I think that's most of what I had to say. Take home messages, like I said, it's difficult, there's not much evidence. From an exam point of view, the Berlin definition is what you'll need for ARDS. For your exams, and the ARDNet can be quite useful. Practically, look at the patient rather than the numbers, particularly pre-intubation, to help you decide when to do it. Try and avoid doing harm, so use lung protective ventilation and avoid hyperoxia. Proning's good. Get used to doing it, use the checklist. And reducing oxygen demand is something that we can do. So paralysis can help with that. Controlling fever can help with that, because it reduces your metabolic demand. We've used the Arctic sign in patients that have persistently got temperatures of 39, 40. And then inverse ratio ventilation, as I said, it increases your plateau pressure, so your average high pressure, without increasing your peak pressure, and therefore increasing your risk of pneumothoraces and pneumomediastinum. The different subtypes of COVID-19, all patients are different, and we're finding that actually it's a bit of, they're not definitely one type or the other. There's definitely a mix between the two, and patients may move between the two different types. So it's using experience and trying on the ventilator. If you make it worse, move it back to what it was before. If you make it better, great. But most of ICU is trying something, and if it doesn't work, try something different. So that's the best advice I can give you, is to try fiddling with the ventilator if you can. Maybe have somebody, if you're not sure what you're doing, have somebody stood next to you, watch what they do. And just, that's the only way to learn, really, is to just try and do it yourself. That's how I learn. So that's it. I know a question just popped up at the bottom, but I didn't get to read it. So if we stop sharing, then people can ask. It's probably the best way of doing it. So anybody have any questions they wanted to ask?
As Dr. Whitman was the star of the show today, because it was what you put in your feedback to us, we'll have a couple of questions now, and then we'll just reassess what we're doing. So Zoe, can you see that chat question there?
No, how do I get chat? Oh, hang on. Right, hang on. Are type 1 patients less likely to intubation as type 2? Most type 1 seems to happen early, so and then type 2, they tend to move into type 2 after about 10 days of ventilation. Probably difficult to answer. I would have thought most of the patients that you intubate will be type 1, but not everybody obviously will need it. So there's a lot of patients who will end up like that who obviously don't need to come to us. Yes, the implication of moving to type 2, there's probably quite a significant portion of that being ventilator-associated lung injury. So trying to ventilate them the best that we can to minimise that definitely makes a difference to outcome. How much of it is related to ventilator injury and how much of it is related to the disease. Obviously, we don't really know because there's not been enough time to get enough evidence for it yet. So I would say just try to follow the lung protective ventilation strategies as much as you possibly can to try and minimise injury. Any other questions? Is IV paracetamol still seen as bad? So IV paracetamol, the nurses want you to prescribe it all the time if the patient's got a fever. There isn't any evidence that it makes any difference to outcome just in general for like normal sepsis, whatever. If you've got somebody who has a temperature of 40 though, I suspect it's quite a good way of getting their temperature down. It probably doesn't do harm, but it doesn't generally change outcome. We tended, like I said, we tended to put people on the Arctic sun, but we only had 2. So when we had 30 patients, we did use paracetamol quite a lot. Anything else? I knew I was going to get asked about APRV. Okay. It's kind of hard without. It's easier to do it when you can see it on front. There is a very good BJA education article written by Dr. Sampson, who's one of the Glenfield ECMO consultants, that was published in BJA Education, I think the February edition this year, which explains it probably better than I can, because it has pictures and stuff. But basically, APRV stands for airway pressure release ventilation. And it's kind of completely the opposite to normal ventilation. So normally when you breathe in, you increase your intrathoracic space and create negative pressure and get it in. And basically, APRV does completely the opposite. So it puts you, for a prolonged period of time, puts you at a high pressure, and then you very briefly release it. So normally my standard settings, when I initially set somebody up on APRV, I will put them at a P high, so your high pressure, which is kind of equivalent to your inspiratory pressure on BiPAP. I set it as somewhere between 25 and 30. Your P low will be 0, so you don't have PEEP on it. My T high, so my time at a high pressure, will be probably about 4 to 5 seconds. So they're staying at a high pressure for a long period. And then your T, and that's what you need to adjust. So you need to make sure that your time at the your low pressure, so your time at 0 is very short, and that is so you don't want their lungs to empty completely. You want them to, because if they empty completely, they will just collapse down and you'll have no PEEP at all, which is obviously what you set. So your T low will normally be about half a second ish, somewhere between 0.4 and 0.7 of a second generally. And you need to look at the flows to do that. It's very difficult to describe without having the pictures, so have a look at the paper that Kaz wrote, because she explains it, but it's at about 75% of your maximum when you T low ends. The idea of it is that you spend a long time at a high pressure, but that high pressure is less than 30. So you're reducing the risk of pneumothoraces and stuff. So it's to it's a way of recruiting, basically. So you're trying to open up as many alveoli for gas exchange as you possibly can. It doesn't, so it's good for oxygenation, it's crap for CO2 clearance. If you've got somebody paralysed, it's not very good because their CO2 won't clear and you'll end up hypocapnic and the nurses will get upset. So all of your CO2 clearance, in answer to the question that just popped up, is done by having them spontaneously breathing. But you need to make sure that the sedation is right so that they're able to breathe. If they're not breathing, you need to reduce the sedation to get them breathing to clear enough CO2 to make it work. So you should think of APRB as a spontaneous breathing mode, it's not like BiPAP. They do need to be breathing to get their CO2 clearance. They probably only have quite small brackets on top, but that's fine as long as if they're making some ventilation, spontaneous ventilatory efforts, then they will probably clear their CO2 to an adequate amount. It will usually be a bit high, but as long as they're, like I said before, as long as their pH is greater than 7.2, they won't get too stressed about it. But it can be very, very good for oxygenation, and it's a good way of testing whether they're recruitable or not. If they get no response to APRB, doesn't bring their FiO2 down, they may not have recruitable lungs, and proning may not help either. It works brilliantly. Some patients it's terrible. So yeah, did that make any sense? Like I said, read Kaz's article, it's really good. Anything else? Okay, good.
Okay, thank you, Zoe. That was really good. So we're coming up to an hour now, and we had a couple of other presentations, but I do wonder if an hour of Zoom is the maximum that most people can put up with. So what I think I might suggest is we can put it in the chat if anybody wants to hear my little physics talk, and we'll definitely roll Shiv's physiology and pathology talk through to next week. But if you want to stay, you can stay. If not, we can just roll it all next week. So what do people think? Do you want to just put it in the chat rather than shouting it out on the screen?
Oh.
Yeah, people aren't fed up of us. Oh, yeah, that's good.
Right.
Okay, so well, you can.
Right, I'm going to go back to work.
Cure the sick. Thank you very much. People having to go back
See
to
you later. Bye bye.
Thank you.
If people have to go back to work, I am recording this, and I will edit out all the awkward trying to get stuff working moments and put it up on YouTube and send the link out so people can see. I'm just going to talk a little bit about physics of ventilation and some of the equations that you need to talk about in your exam. And then I know Shiv's got about 3 hours on the pathology of lung ventilation, so we'll do that next week. We also had a bit of a quiz, but without all three components, it won't make a lot of sense. So we'll roll that over again later as well. So let me just have a little play with this to get it up. So what I was going to do is just do some of the physical principles of ventilation and the physics that underlie it. And really we're cheating a little bit with this because the equations that govern how you ventilate somebody and how gas moves within the lung are exactly the same as flow dynamics. So if you've learned them for arterial pressure and venous pressure and stuff, they're effectively the same, but we thought we'd go through them again. So we'll look at the equations governing flow dynamics and have a little chat about those. I've got a bit on lung volumes as well, and then there's a bit on ventilation circuits. Now, ventilation circuits, when I was a CT, really confused me, so I've done a little summary of it maybe to hopefully make it a little bit more straightforward in the way of thinking it through for you. So in terms of flow, we know there are two different types of flow. There's laminar flow, which is shown at the top diagram here. And the way to think about this is that there are layers of molecules within a pipe, either gas or fluid, and these run in layers, and those layers move across each other in a laminar method. That's why it's called laminar. And the flow at the centre of the pipe is faster than the flow at the edge, and in terms of physical principles, we say that the flow diminishes to almost zero at the wall. The other option is turbulent flow, which is the one we see at the bottom here, where there are no discernible layers of flow, and everything moves in a random direction, but generally from one end of the pipe that you're looking at to the other. So there are a couple of important equations, and especially those that haven't done your Vivas and things yet, these are the ones that you're going to need to trot out quite easily. The one that determines laminar flow, and is the most important one you get asked about there, is the Hagen-Poiseuille equation. And in this equation, it equates flow to what you see here. So it's pi, so because it's a circular tube, and then P stands for the pressure drop. So that's often represented as P or delta P or P1 minus P2. But that's the difference in one end of pressure to the other end of the pipe, obviously. And then radius to the power of 4. So as the things on the top of the equation go up, your flow increases because the number at the top becomes bigger. So as your pressure differential, i.e. you push something harder, increases, then your flow increases. But the most important element here is actually radius. So a small change in radius is actually to the power of 4, so it increases the flow much bigger. And this is especially important in both flow through blood vessels, but also flow through the lungs. So as your bronchioles get smaller and smaller, your flow gets less and less to a greater factor. And the same thing goes for like laryngomalacia and stuff. So as your radius decreases, you end up with a big change in flow. The bottom half of the equation is a constant, so 8, and then you've got the viscosity of the fluid. Now, I've got it represented there with a little mu, but sometimes it's represented with a theta, but I couldn't find the theta on the Microsoft thing today, but the same numbers are the same, and then the length. So as the viscosity of the fluid increases, flow decreases. And if you think about the different layers within the flow of the tube, if your layers are thicker, they move across each other slower, so your flow decreases. And obviously flow, as your pipe gets longer, will be slower. So the most important thing there is the radius. Change the radius and you change the factor a lot more. But viscosity is the most important thing to talk about as well in terms of the fluid that we make up. Now, we can change viscosity by reducing hemocrit and other bits. We'll come on to that in turbulent flow a little bit more. You sometimes see the flow equation or the Hagen-Poiseuille equation shown as the little number down there. So pi times pressure difference to the diameter to the power of 4. And then the constant becomes 128 then. Because you've effectively got a radius doubled, you have to add a 2 to the power of 4 on the bottom. And 2 to the power of 4 times 8 is 128. So you sometimes see a secondary equation given there. It's just a simple bit of maths. The one that determines turbulent flow is a number called Reynolds number. And Reynolds number is equivalent to the density of the fluid times the velocity that the stuff's moving at and the diameter of the tube divided by the viscosity. So if you think about this again, the more dense your fluid, the more likely you are to get eddies within that current of that fluid, and the more likely you are to have turbulent flow. The faster something moves, the more likely you are to have turbulent flow as well. And the bigger a tube is, the more likely it is to produce turbulent flow. And then viscosity is the other way around, obviously. The most important number here again is density. Now the thing about Reynolds number, and it's always taught with Hagen-Poiseuille as if they're the same thing, it's not. Reynolds number works out if the flow is likely to be laminar or likely to be turbulent. So it doesn't tell you anything about the nature of that flow, as in how much is going to flow, but it tells you if you're likely to produce a turbulent or laminar flow within a pipe. So a more dense fluid is more likely to be turbulent, that's moving faster. And you can probably people have done this, apply this to blood moving through arterial line pipes and things. But again, this is just an equation that you need to be able to trot out and understand the differences. The other thing that we know about flow, especially when it comes to ventilation, is the Bernoulli principle. So the Bernoulli principle says that as the it's based on the law of conservation of energy. So if the flow velocity of a fluid or gas goes up, something has to go down. So you get a reduction in pressure. So if a fluid speeds up, the pressure of that fluid goes down. And that is to maintain the amount of energy contained within the system. And we use the Bernoulli principle in the Venturi effect. So in a Venturi effect, we introduce a constriction to the fluid or gas flow within a tube, and that increases the velocity of the fluid because it's going through a narrower tube at that point. So it has to go faster to maintain the mass that's moving through. But we can't gain energy from anywhere, so we have to maintain our energy equilibrium, which means the pressure of the fluid drops. So as you see in this diagram at the bottom, you've got high pressure, low speed fluid, and in a constriction, you've got low pressure, higher speed fluid in the constriction, and then after that, it goes back to the same number. And that's really useful because we use that in Venturi devices. So if you were to introduce a side arm at the point of that pressure going down, you can use that lower pressure to entrain fluid or gas into that area. And in a Venturi device, especially the ones that we use as a fixed oxygen delivery device, you control the change in pressures, which means that change in pressures is controlled by the constriction. And so you can how much is sucked in and how much room air is brought in. So basically, as your oxygen flows in through the input, a variable orifice, a fixed orifice changes how much is sucked in. So your oxygen comes in, the suction here, it's shown liquid, but it can be room air to dilute it, and you get a fixed output. The important thing here that I really like as a little sort of teaching fact is that turning up the flow on a Venturi device does not increase the oxygen that's delivered to the patient. So if you've got a Venturi device that says use 10 litres, if you turn it up to 15, you introduce turbulence within the chamber, which reduces its efficiency. So if anyone's turning up the Venturi device to an extra strong level, you're actually giving less oxygen to the patient than you think you are. And then the other principle that we need to think about is the Coanda effect. And in the Coanda effect, if you've got a curved surface, if you have a fluid that moves across that curved surface, the fluid or the gas will follow the line of the surface rather than the original course. So in the diagram in the bottom left here, your force is running in a straight line across the diagram. And because there's a curved surface away, the area of low pressure is generated at that surface. And that comes back to what we were saying about laminar flow having low pressure at the periphery, and it therefore follows that. So this is important in bifurcations in lungs and things. You may get gas flow in a different place, and also in arteries as well. The other important thing that we do is the diagram on the right. So if you ever hear a ventilator making a noise, it's using a thing called fluid logic. So in fluid logic, you place two control valves on this flow, and you can basically push the flow down either tube. So this is how your Oxylog 3000 works in inspiration and expiration. If you've got a flow in the bottom diagram there that's flowing along that bottom tube and you want it to go, and that's say inspiration, if you want to then divert it somewhere else, you push carrier gas up that control nozzle, and it pushes it up to the other thing, and it will always stay there due to the Coanda effect. I think lung volumes is something that I'd also added on as well. The best thing here to do is go away and look at the diagram and think about it a little bit yourself. I'm sure most of you know it by now. The important idea here is that tidal volume is your resting volume that we have in the middle here, and that's what we're doing as we sit at rest. We then have an inspiratory reserve volume, which is the maximum breath we can take in. So that's, cycling at your 25% incline in the Alps. And then the expiratory reserve volume is the maximum you can breathe out. And you have a residual volume at the end, which is the fifth bit left at the end. And they really like this in vivas because it's a really easy question for them to ask, and you can just reproduce this. You then have a number of capacities. So inspiratory capacity is your maximum that you can inspire in any one go. And then a functional residual capacity, which is basically your expiratory capacity. And that's what's left in the lungs at the end of normal tidal breathing. And two volumes added together make a capacity. And then you get vital capacity, which is the maximum amount of breathing you can do, and then total lung capacity as well. I would go on and do stuff about spirometry and lung volume measurement, but I really don't understand it, so I'm not the person to teach it. And then FRC, like we said, so the important thing here is it's the amount of gas that remains in the lung after a normal tidal volume. It's usually about 3 litres in the average person. We then introduce this idea of a closing volume. So there is a volume of gas where your small airway starts to collapse when you go below that amount left in your lung. And in normal healthy individuals up to the age of 40, this is not a problem because you've always got a greater volume of gas in your lungs than that closing volume. But at 40 years, when you stand up, you can start to encroach on that. When you're laying down, and then about 70 years when they're standing up, they can get a closing volume. So the small airways start to collapse at the end of normal tidal expiration at around 70 years. It's obviously important for ventilation. So the other thing I was going to talk about is the Mapleson classification of circuits, because again, this is an area that really confused me, and I just wanted to simplify a little bit for. So this is William Mapleson. Sadly, he died last year. He was 92 years old when he died. And he was applied to the anaesthetic department in Bristol for job experience. And he basically went just to get an interview experience. And he never had an intention of taking up the position. He got offered the job and was there for 40 years and did 40 years worth of anaesthetic research. And he's got all sorts of medals and things after his name, published many, many papers. One of the first things that Mapleson was given, he was given a big bag of ventilator circuit pieces. And he was asked to come up with a way of assembling these and working out the flow dynamics through it. And that's where he came up with the Mapleson system. So it wasn't actually deliberately designed. He just put them all together in the different options that he could think of and then worked out the flow dynamic characteristics of all of these. So in a way, that's why they don't always make sense. So the Mapleson A, it's called the McGill system. It's an afferent reservoir system. So basically your fresh gas flow passes through your reservoir first, which means that you have a reservoir of gas to use when you either breathe in or you do positive pressure ventilation. So it matches the patient's volume and not the flows. The important thing to know about a Mapleson A is that it's good for spontaneously breathing patients. And it's also available in a coaxial system, which you sometimes see in anaesthetic rooms. So you often use this in a spontaneously breathing patient. It's bad for positive pressure ventilation because what happens is as soon as you squeeze the bag, the valve opens and it blows gas out in the air. So you need about 2 to 3 times a minute ventilation in positive pressure. So you need a high gas flow. So an A circuit is good for spontaneous. It's a key thing to get across. Mapleson B, I've never seen one of these in real life. It's very rarely used because all the stuff is at the patient end. So the fresh gas flow and the circuit and the valve at the patient end. So it's quite cumbersome and heavy. And it's rubbish for everything. So in spontaneous breathing, you need 2 to 3 times a minute ventilation. And in positive pressure, you need the same as well. So it's very rarely used. But what he then did is he took that corrugated tube out and made the Mapleson C circuit. And everybody calls this a water circuit, which isn't actually true. A water circuit has a CO2 scrubber in it. And that just, appeals to my pedantry. And the important thing about these is they're small and very portable and easy to use. You'll often find them on intensive care. They often call them bagging circuits on paediatric intensive care. And if I catch any of you lot doing that, you'll be in trouble. And these are, again, not great for spontaneous ventilation and not great for positive pressure because they still need a high volume to go through them. But they are pretty easy, pretty cheap to produce and easy just to hang up on the back of the machine. It needs a high flow to prevent rebreathing because you don't have that corrugated bit of tubing, and it needs a high pressure to inflate the bag. But overall, for an anaesthetist, they're pretty reliable bits of kit. Then you get down to the Mapleson D, which is sort of really the inevitable conclusion of Mapleson moving the bits and pieces around. You get a coaxial version of this called the Bain system. And essentially it's the adult T-piece. So it's a T-piece with a closed end bag stuck and a valve stuck on it. And the good thing about this is that it's very good for positive pressure ventilation. Not so good for spontaneous, but good for positive pressure. And all the books talk about, oh, it needs 70 to 100 mils per kilo per minute of gas flow. But if you work that out on an average adult breathing 10 breaths a minute, say, that's about 7 mils per kilo. So actually it's 1 times minute ventilation, roughly speaking. So 2 to 3 times minute ventilation for spontaneous, 1 for positive pressure. And the good thing about this, you know, the fact to drop in your exams is that it's useful in MRIs, the resistance is really low, and you can make that tube as long as you want it, so it can be outside the machine. And dropping in that sort of stuff in exams not only gets you marks, but makes you look like you've done the work, so it's quite a useful fact to know. And then moving on to where I'm happiest, I seem to have not bothered cutting and pasting it to get rid of the other pictures here. A Mapleson E, so also known as the Ayres T-piece. It's also known as this because Ayres invented it before Mapleson, and he borrowed the idea. And the nice thing about a Mapleson E is it's very simple. It's just basically a plastic tube with a bit of gas going through it. It has ultra low resistance, so there's no bag and there's no valve, which is really good in paediatrics. And again, spontaneously breathing is pretty rubbish, so 2 to 3 times minute ventilation, but positive ventilation is pretty good. And again, the books always talk about 200 to 300 mils per kilo per minute. But if you work that out in a baby breathing about 25 breaths a minute, that works out about 8 mils per kilo. So again, it's minute ventilation. And this number's higher because it's got a higher metabolic rate in children. And then what they did is Jackson Rees, who was a famous Liverpool anaesthetist who did lots of paediatrics, he modified the Ayres T-piece because the problem with the Ayres T-piece is there's no bag on the end and you can't use it to monitor anything. So he stuck a plastic bag on the end and cut the end off, which allows for us to monitor it. And if you've ever done an anaesthetic with me, we use the T-piece all the time and we watch the bag moving more than anything. We don't even look at the monitor. And you can also ventilate through it, and you can vary the peak by including the bit at the end. But again, resistance is ultra low because there's no valves or anything going through there. Spontaneously, pretty bad again, 2 to 3 times minute ventilation, so quite high. But again, IPPV, so positive pressure. And again, if you work this out, 200 to 300 mils per kilo per minute, roughly 25 breaths a minute is about 8 mils per kilo. So again, it's about spontaneously breathing. About minute ventilation. So what I really wanted to do is to highlight this is the history of these things is actually quite